This week on the BackTable podcast.
It's very invasive and uncomfortable to think about undergoing endometrial biopsies, routinely, and then in whom would you do that? And so there's a lot of interest in research happening in that area about, is there a high-risk population? And we know, for example, that patients with Lynch syndrome, or those patients who have a genetic or inheritable risk for endometrial cancer and colon cancer, are right now the only population sort of approved by national guidelines for screening after the age of 35 because of their higher overall population-based risk of cancer. However, there are studies happening at centers like WashU, Hopkins, Mayo Clinic, where we're looking at novel approaches to potential screening that won't be as invasive.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com.
Welcome to another episode of BackTable OBGYN, and this is Amy Park, one of your hosts. Mark is not with me today, but I'll shoulder on myself, and it is my great pleasure to host two esteemed gynecologic oncology colleagues, Dr. Matthew Powell and Dr. Amanda Feder. I cannot do justice to introduce yourselves, so please tell me a little bit, and our listeners, a little bit about yourselves and your interest in the topic that we're going to discuss today, which is rising endometrial cancer rates.
Amy, thank you so much for having us today. It's wonderful to be here on BackTable. So I'm Amanda Feder. I am a GYN oncologist based out of Baltimore, Maryland, and I'm at Johns Hopkins Hospital. I've been at Johns Hopkins for more than a decade now, and I'm also the current president of the Society of Gynecologic Oncology. And for as long as I can remember, since I was a fellow, I've been fascinated by endometrial cancer, and particularly the rising rates of endometrial cancer and the rare endometrial histologies that may be contributing to some of this. So I consider myself a rare tumor girl. I direct the Gynecologic Rare Tumor Center at Hopkins and am a clinical trialist as well. Very interested in moving the needle in both prevention and treatment outcomes for patients with this disease.
And I'm Dr. Matthew Powell. I'm a gynecologic oncologist at Washington University School of Medicine in St. Louis. I've been here, almost 25 years. And main area of research interest is endometrial cancer. For the National Cancer Institute, I chair the year-end committee through our group called the NRG Oncology. And I've been doing that for about 6 years now, and help leading a lot of the clinical trials across the country, or actually across the world, that touch patients with endometrial cancer. So certainly a passion for both Dr. Feder and myself.
Amazing. Well, we're so lucky to have you guys on this. I've been hearing about this for the last couple of years, and I'm a urogynecologist, so I don't have any content expertise in this topic. But can you touched on this, Amanda, a little bit earlier, but can you describe the different types of endometrial cancer and what the epidemiology has been historically?
Yeah, so there's two basic categories of endometrial cancer: endometrioid and non-endometrioid cancers. And the vast majority of patients that are diagnosed with endometrial cancer have the endometrioid subtype. These tumors tend to be estrogen and progesterone receptor positive. They tend to develop in patients with overweight or obesity, and in many cases are low grade and early stage. Not in all cases, however. There's certainly a subset of patients with this disease that have more advanced stage or higher grade tumors, but they represent the majority of patients with this disease. Whereas the non-endometrioid subtypes are some of those poor prognostic, rare types of cancer, like the uterine serous, the carcinosarcoma, the clear cell subtypes, and some of the mixed tumors as well. We're now looking at endometrial cancers, not just in terms of these histologies, but in terms of molecular differentiation, to really help us understand the biology behind the tumors and what patients with these tumors might best respond to in terms of treatment.
So what's going on right now? I mean, it sounds like the epidemiology, is that changed, or has it been rising rates in the type 2 or the non-endometrioid cancers? What's going on right now?
So yes, the kind of two main things going on. One, we have an obesity epidemic in this country, and that's driving elevated risks of endometrial cancer. And most of that is through increased levels of estrogen. As people are heavier, they get more conversion of some hormones into weak estrogens, and this causes the lining of the uterus to kind of grow and grow and grow. And over time, that accumulates enough damage to result in cancer. So the obesity epidemic is certainly one. The other thing is we have an aging population. So as we get older, we're more likely to get these cancers, and there's more people at risk. So the baby boomer population that's now in the retirement phase, that's where we're seeing a lot of cancers. And if we look across the world, there's about 425,000 cases of endometrial cancer. And in the U.S., we represent about 15% of all the cases worldwide. So really, with our obesity epidemic and our aging population, we see a large portion of these cases. It is a disease somewhat of the Western world, but about 3% of all women will get endometrial cancer in their life. And thankfully, the vast majority will have disease confined to the uterus and do well. So about 80% of patients do well, but unfortunately, 20% of patients will have trouble with this cancer, and where they can get metastatic disease and ultimately succumb to the cancer. It is now our most deadly cancer. Ovarian cancer used to be the most deadly, and then this year it looks like endometrial cancer is going to surpass that. And as you mentioned, it's because of these higher grade, higher risk types. And these are the types that not only affect our older patients, but also disproportionately affect our African American and Black patients. So we have a big effort now to try to sort out why and try to get the word out that abnormal bleeding is a big problem and that needs to be addressed by patients.
Oh, if I may add to that, endometrial cancer is the fourth most common cause of cancer in women in the U.S., but given some of these trends that Matt is talking about, we are set in 2030 to see endometrial cancer overcome colon cancer to become the third leading cause of cancer in women. So these are really, really disturbing both incidence and mortality trends. Like when you look at all cancers together, while most solid tumors in the world are decreasing in incidence or plateauing in incidence, endometrial cancer is one of the only cancers that's rising in both incidence and mortality for many of the reasons that Matt described. And so this is a real call to action here and a huge public health threat for women.
We should probably point out that you don't have to be overweight to get this cancer either. It's not solely due to that, but that's a big factor in developing the cancer. So, there's nobody's safe, I think, is the issue with endometrial cancer with it being such a high prevalence. 3% of women get this cancer in the United States.
Yeah, it sounds like what you alluded to, Matt, is that it's really powered by a lot of, there's like a disparity in who's getting the more lethal cancers or the ones with the worst prognosis. I know you alluded to this earlier, but can you go do a deeper dive? Like what's going on there?
We don't entirely understand why there is a racial disparity. We knew patients with African ancestry tended to do worse. They didn't have as high a rate of getting the cancer, but when they got the cancer, it tended to be this non-endometrioid type and was much more associated with death. So about twice the risk of dying when they do have endometrial cancer. We actually have a lot of research ongoing looking at environmental factors, molecular factors. I know there was some implications of hair straightening chemicals that may be a portion of this. And then there's a declining rate of hysterectomy in this country. So when we correct for hysterectomy, we see this rate really go up. And that's so people that still have their uterus are in very high risk. And we're doing a lot less hysterectomies than we did in the past. So I think that's another part of what's going on.
Oh, that's so fascinating. I hadn't even thought about that.
Yeah, it's like I think when we were all in training, there was an instance of like 600,000 hysterectomies a year, and that's I think the most recent data shows about 450,000 are being performed now with so many interventional and conservative management techniques. And in addition to that, you're seeing increased tamoxifen use amongst breast cancer survivors, for example. So as studies have shown that prolonged tamoxifen use may be beneficial to select breast cancer survivors, we know that tamoxifen is also a risk factor for endometrial cancer and increases that risk by fourfold. So all of these factors, coupled with the lack of community knowledge about the symptoms of the disease and when to present for care, and lack of knowledge by some providers as well, not just by persons in the community. We have just a cluster here of different factors sort of converging to lead to these increases in rates.
Does the decrease in childbearing or I mean, less exposure to birth control pills or any of that stuff also contribute? I don't know if that's those are factors or not.
Yeah, so, birth control pills do help prevent endometrial cancer, but you also see in women that have not had children, they have an increased risk of endometrial cancer. Also, women have had some infertility, typically the diagnosis of polycystic ovarian syndrome, hypertension, and diabetes also are independent risk factors for the development of endometrial cancer. So we see a lot of these patients have diabetes. They get an abnormal kind of hormonal syndrome going on that leads to this increased risk of endometrial.
So, like, for our listeners, what are the signs or symptoms that we need to be looking out for? I mean, I know postmenopausal bleeding is one of the things, but what if they're premenopausal? Like, how do you screen for it? What are the things that you guys think are getting missed when the patients present to you?
I think that's a really great question. Matt, if you don't mind, I'll start with this answer. So the good news is that this disease is largely preventable. This is a modifiable, preventable cancer in not all cases, but the majority of cases. And the onset of the cancer is almost always heralded by some sort of bleeding. So in postmenopausal bleeding, we know that any bleeding, spotting, discharge is abnormal, and we would recommend women immediately seek care in that situation. But we're seeing with the increased obesity and polycystic ovarian syndrome and other diabetes, as Matt said, so many different metabolic syndrome diagnoses also going up. We're seeing the incidence of endometrial cancer increase in younger women. And so premenopausal women can experience abnormal uterine bleeding. And that can manifest in many different ways, from bleeding between periods, prolonged heavier cycles, shorter intervals between cycles. And there was actually a study done by my colleague Anna Beavis here at Hopkins that we looked at a population of women here, premenopausal women who had undergone endometrial biopsy and evaluations to determine, can we do better than our current guidelines in terms of pivoting to performing a biopsy in these patients. And she interestingly found that, not surprisingly, increasing obesity and the incidence of obesity as well as diabetes, and in certain ethnic racial groupings, especially in Black and Hispanic women, in those populations had an increased incidence of pathology on endometrial biopsy when it was obtained. And so I would just encourage women, who have any irregular bleeding in the premenopausal setting that just doesn't seem right, or a change from prior trends, or any postmenopausal women with bleeding, to immediately, present to their physicians. And then, providers, I think, need to be very astute about this and, not blow off these symptoms. And unfortunately, I know Matt and I see, not all the time, but not uncommonly, we'll see patients who, presented for care to their physicians, and they had this concern, and, we're told, okay, well, it's probably just perimenopause, or, because you missed your pill. And so these women are not always evaluated diagnostically for this problem, and delays in care can occur. And there's been a lot of literature about this as well. Kemi Dahl, one of our GYN oncology colleagues from the University of Washington, writes about this, how you can have these vulnerabilities in care cycles that women actually present to care but are not necessarily triaged appropriately and undergo the proper workups. And so that can affect, a delay in diagnosis and a delay in treatment for some patients.
What are your thoughts about the pelvic ultrasound? Because I know for screening, and if you look at the guidelines for postmenopausal women, at least, looking at the lining, I know it's not as good as catching the non-endometrioid, type cancers. Like, what are the warning signs? I mean, I see so many older patients. It's so hard to figure out if this is like a little bit of discharge. Is it some pessary juice? Like, what's going on here? You know what I mean? So like what would be like your little, just low threshold to biopsy? I mean, that's what I literally have a low threshold to biopsy, endometrial biopsy or vulvar biopsy. I catch a lot of VIN and vulvar cancer, actually. So I just biopsy a lot. But what are your thoughts? Because you guys see these patients after they present for care and it's too late.
Yeah, I'd give you two caveats. One is we used to say any abnormal bleeding over age 35 should be evaluated. Now, throw that out. I think, especially with adolescent obesity, we're seeing young 20-year-olds getting endometrial cancer. So really, if they've had irregular menses for a long period of time or for more than 6 to 12 months, I think they need to be assessed, even if they're in their 20s. So take that caveat. And the other issue about use of ultrasound, you point out, ultrasound does a good job picking up the type 1 endometrial cancer. So the garden variety endometrial cancer, you'll see either a polyp or thickened lining. You're going to see an enlargement of the lining. Usually in the postmenopausal state, we use something 5 millimeters or greater to really want to proceed with a biopsy. Now, it doesn't do a very good job picking up the non-endometrioid cancers. So especially our African-American patients and our very elderly patients, if they're bleeding, you really want to think about a biopsy because it could represent a serous cancer. And the tricky part is there's obviously a lot of cervical stenosis that can happen. You know, sometimes just it's mucus in the lining of the uterus that you're seeing. But really, if they've had symptoms or there's thickening on the ultrasound, error on biopsy, I think, is the key. And if you get a negative biopsy and they're still having symptoms or problems, make sure you're following up with either D&C or even moving to hysterectomy in somebody that maintains persistent symptoms.
Can I just ask you guys what your thoughts are? Because this has been coming up repeatedly, like doing these biopsies and cervical procedures. Women are saying it's so painful. Do you have any tips and tricks, like the IUD controversy and like women not being offered analgesia? There's a lot of fear around having procedures, etc. What are your oncology tips and tricks that like help the pain aspect and, you know, just counseling or verbal analgesia or whatever you do? Because I feel like these are some of the things that prevent physicians and NPs and all of the people on women's health team from really having a low threshold.
Yeah, I think that's a really excellent point, and meeting patients where they're at is really important. And there's obviously, on top of all of that fear, there's a stigma still associated with talking about some of these topics, talking about I'm having vaginal bleeding. You know, we want to normalize a lot of that in terms of discussing it openly and publicly. But I think it's important that patients, that we understand as providers, that these are not exciting procedures. No woman likes to undergo a biopsy, let alone a pap smear. But I would say that they're incredibly important. And the literature on whether anesthesia helps in these situations is really mixed. In some of the studies, it shows, that it could be just as uncomfortable to have a lidocaine injection at the cervix, while in other studies shows that the significant discomfort is alleviated with analgesia. And so having a conversation with a patient about this and understanding their preferences and their fears and concerns, I think is really important to help them feel comfortable about this. I think talking to patients about whether they'd prefer doing something under sedation or in the office is important as well. But I don't have a magic bullet for this. I don't know how you handle this in your practice. I do offer, some of my patients do end up using some local anesthesia, others do not. And in some cases in postmenopausal women, I find that in 30 to 40% of cases, we may not be able to do a successful biopsy in the office because of discomfort or stenosis or atrophy, or there's a pathology there that prevents us from doing that. And so I think defaulting quickly to offering, a procedure either in the office with some sedation or within an operating suite or an ASC, I think is reasonable.
Yeah, I think it's a quick way to make enemies if you don't have them well prepared. And it's really often the uterine cramping that really gets them. So the cervical dilation is usually not the part that hurts. So the paracervical block, I wish it would do better than it does. And, the patients there get a severe cramp and maybe even a vagal type reaction, their uterus, usually because of the endometrial biopsies, cause some severe cramping up in the uterus. Usually, as you just said, good counseling, a lot of patients, they're not excited about having to go to the operating room to get an anesthesia either. So it's a delicate balance and every patient has to be individualized.
I know one of my colleagues, Linda Bradley, she is such a proponent of doing office hysteroscopy. She gives meso at a drop of a hat, some PO Ativan, all the things like magnesium, I guess. I was just doing a co-case with her the other day and she gives IV magnesium to help with the cramping postoperatively. I hadn't heard of that trick, but I haven't dilated somebody in a long time. But in any case, I think, it's just when you get into the day-to-day of your clinic, and you're like looking at your template and you're like, oh my God, I have to, especially for a generalist, I have a little bit more time on my template, but it's like, how are you going to, they're like, oh, by the way, I have some bleeding. And then you got to like get them to that point. And I know for me, oftentimes I'm like, let's just take care of this while you're here, because I'm never sure when they're going to come back, like you want to catch them when you can. But I think having the right kind of counseling mechanisms where you can just have your spiel to be like, okay, I really want to diagnose this. We just want to make sure it's nothing bad. Let's just make sure. And then if you have a pretty high suspicion for this, we usually wait for the tissue diagnosis before sending to gyn-onc. But like, where do you guys stand on there's all these terminology now, but I know it's called EIN. Is that something usually is referred to gyn-onc or generalist, or how does that work?
Well, I think this is a variable practice at our center and within our system, because EIN, or pre-invasive disease, is associated with upwards of a 40 to 45% risk of cancer on final hysterectomy specimen, especially if there's complex atypical cells seen, under the microscope, which is by definition EIN. We manage this, the GYN oncologists manage this at our institution. I think it's important that whoever is managing this is a very high volume provider, can counsel patients about the risks of underlying malignancy, can appropriately and surgically stage the patients in those cases if needed. And at our institution, we generally will perform sentinel lymph node biopsies because there's such a high risk of concurrent invasive cancer in this population. And so I think what's most important is understanding that the patient is getting the care from the right provider. So right provider, right time, right procedure. And in most cases, the GYN oncologist is going to have the most experience and have the highest volume approach to managing those patients. I don't know, Matt, if you do the same thing at your institution.
Yeah, I completely agree. And, sometimes we'd use the amount of thickness on the ultrasound to help us gauge whether there's, higher risk of cancer than 40%. But in reality, it's just not accurate. And we do tend to err on performing sentinel lymph nodes. It's not, that's certainly not uniform. I mean, across our practice and across the country, if I have a cancer or precancer, I want to have as much information to help guide the patient as we can. There's nothing worse than, you're post-op having the uterus out, you have a deeply invasive cancer, then you're not so sure about whether how to follow that patient, because, the lymph nodes certainly are at risk, and how best to follow that patient is a big controversy. So if we can take the sentinel lymph nodes out with really low morbidity, more information, the better to help us in this situation.
There must be gyn-onc desert. So I've seen Jason Wright's info, his data looking at these oncology centers. Like how does that work when you're not in close proximity? I mean, a lot of people have to travel quite a far distance, right?
Yeah, we actually did a study on this at Hopkins. One of our fellows, Nerlene De Ravine, actually presented this work last year, and it was about the geographic disparities in gynecologic cancer provider, the workforce. And there are, we have so many at-risk women for gynecologic cancers, and especially for endometrial cancer. And it was staggering how many thousands of counties, and surrounding areas had no GYN oncologist for more than 100 miles or more away. And so we do, I think the geographic disparities in care contributes some to the overall, there's multiple A's to disparities, access being one of them. And that's something that we're grappling with in our field right now, is how do you get subspecialty, especially preventive care and some treatment, to these rural areas where, it might not be feasible. And so having rural urban partnerships with hospital systems and clinics, I think, is happening. And increasingly telehealth has really helped, revolutionize the approach to rural medicine and cancer care. And I think is really beneficial in that regard. But the solutions aren't perfect. And some patients can't travel to the bigger, community hospitals or academic centers to see the highest volume providers. And so we need to make sure that we're training our GYN surgeons in a standardized way, and educating them about endometrial cancer symptoms and other cancer symptoms that women are going to be at risk for, so that they can, really be wonderful multipliers in the community and in the rural settings to help women get the care they need, whether locally or at a regional center.
And one thing I might add is, sometimes these patients might have a BMI of 30, 40, 50, 60. And it's not just me as the gynecologist, it's our anesthesia team. It's the whole crew that's helping take care of this patient, get them through surgery safely. Rural hospitals often may have a limit on a BMI, but they might be willing to put somebody to sleep to do a hysterectomy. Most all of these can be done minimally invasive, either laparoscopic or robotic. And, the tips and tricks that we use to get patients through safely, I think does warrant referral for patients. And I think, obviously the physician around the community, doesn't want to hurt the patient if they're, especially with large obesity. That's never an easy case. That's you have to think about opening the patient for open hysterectomy. That's even harder for a general practitioner out in the community.
The other thing that I know has come up is, the surgery is one thing, but you diagnose the cancer and then the access to the chemo radiation. And then, chemo, I don't know the schedule, but I assume it's pretty taxing, if you're coming from out of town. But then also the brachy, if you're doing brachy, I know one of my friends was the only radiation oncologist in her system to do brachy, and when she was on vacation, brachy stopped. In a conference, there was no brachy happening. When I talked to my radiation oncology colleagues, they were like, well, there was a movement for a couple of years and we're doing, more. They thought that they could get away from brachy. They were doing like whole beam or something more targeted, but then it wasn't the case. And then going back to brachy, there was this whole kind of like generation of residents who didn't train up in it. And then now it's sort of like one of those more rare things. It's actually a differentiator for radiation oncology residencies. So I just wanted to hear what your take is on that, because it sounds like that is actually also a really rough component of this, or not rough, but
it's one of those things we even made a quality metric out of. For brachytherapy for cervical cancer, it became a quality metric through ACS, and because we saw it kind of falling off, especially in rural communities or low volume providers not using it very much. So that's really, the survival is so much better when you can deliver good brachytherapy in cervical cancer. Now, brachytherapy in endometrial cancer is typically also not so much technically challenging, it's just equipment challenging. It's expensive to have the equipment to do it. So it's not offered in a lot of the rural radiation centers. So they usually do need to travel somewhere where there's a high volume provider, allowing them to purchase equipment to do vaginal brachytherapy.
Do you see a disparity in care? I assume there is, but I'm not sure what the data is on it.
Well, so the good news is typically only 3 or 4 treatments are needed for the vaginal brachytherapy. So often patients are willing to travel for that short course of vaginal radiation. But if they need to get combined external, they can usually get that locally. So yes, there's a disparity because, obviously patients aren't sometimes able or can afford travel. But at least it's not so onerous where they're having to come for 6 weeks worth of treatment. They often could just come 3 or 4 times to have their radiation treatments delivered to the high volume center. But there certainly is a disparity there. I think we've tried to narrow it in when we can.
The other thing that, this conversation is just making me think, I saw radiation oncology match was like, they go unfilled sometimes. So I just wonder about the workforce there. We're in an anesthesia crunch right now. I just wonder, are we going to encounter a radiation oncology workforce crunch? Are you guys seeing that? You're at big centers, but is this a topic of discussion?
I think that there's a workforce crunch across so many disciplines in medicine now, especially post-pandemic. But yes, and as we look at the number of patients that will be alive in 2030 and 2040 over the age of 65, as Matt mentioned earlier, we're going to see potentially a rise in several cancers, including a continued rise in endometrial cancer unless we flip the script. So yes, I think across, ASCO, the American Society of Clinical Oncology, performed a workforce analysis, I think it was over a decade ago now, to look at, workforce challenges and geographic disparities across multiple oncology provider types, and predicted a workforce shortage in the 2020s and 2030s based on the demographics of the aging cancer population. And so this is an issue for GYN oncologists, radiation oncologists, and multiple subspecialists.
Yeah, it seems like it's coming to the fore. We're already seeing that across multiple specialties. I mean, urology has been tight for a long, long time. Anesthesia, hearing about, it's like COVID times, not enough people to staff the rooms.
But if we really get back to the heart of this conversation, we're dealing with a preventable cancer here. And if we can, again, educate more women and individuals in the community about the signs and symptoms of endometrial cancer and ensure that more providers, as Matt mentioned earlier, have just a quicker response time to assessing the endometrium in patients who may be at high risk for endometrial cancer, as well as addressing the overall obesity epidemic. It is really something we need to, I think, from a population health level, really commit resources to. And right now, one of the issues is that endometrial cancer research is underfunded federally. And when you look at the funding to lethality score for endometrial cancer compared to some other cancers, we're almost at the bottom of the list. And so my hope is that as we bring more attention to this issue on a policy level and advocacy level, that we'll see a greater number of efforts, both at the federal and foundational level, to fund science and to fund public health initiatives that will help us address these issues so we can prevent more cases.
I'm just going to break it down. So if patient has abnormal bleeding, postmenopausal for sure. I mean, I know what I'm thinking, which is like PAP if you haven't had a recent PAP, and then endometrial sampling and ultrasound are like the top three things that I'm thinking of. And especially in the case of women with risk factors that you mentioned, so obesity, if they're African American, have the hypertension, diabetes, and the premenopausal patient also with the risk factors and haven't responded, it's a little bit harder to rely on pelvic ultrasound because obviously the lining can be variable, but have a low threshold to biopsy, and then increase in funding for research on this. Matt, can you tell us a little bit more about your work with the clinical trials and what's on the horizon, what's currently available and what's on the horizon for endometrial cancer?
Yeah, so the last year has been quite exciting. We've had major steps forward. A lot of this came out of Hopkins with the use of immune checkpoint inhibition. Immunotherapy has really become a standard for patients with metastatic endometrial cancer. There's different types. So we kind of have 4 big molecular types of endometrial cancer, and one of the larger one has a defective mismatch repair. And these cancers are uniquely sensitive to immunotherapy, either by themselves or combined with chemotherapy. And last March, we had 2 studies that came out using different checkpoint inhibitors when combined with chemotherapy dramatically improved the progression-free and overall survival for patients with kind of really bad disease. So they had recurrent disease that you could see on a scan, or they had advanced stage disease. So these are kind of the worst of the worst, and the fairly dramatic improvements with the use of immunotherapy. And it's not just the mismatch repair, but also the group that had P53 mutations seemed to be a benefit, and perhaps all of them had some benefit. The FDA is looking at the data currently and has approved the mismatch repair indication, or MSI indication, but still looking at all the rest of that intervention. So that's a big one. We also have learned to target the HER2 molecule. So just like in breast cancer, HER2 was led by Dr. Fader, and I'll probably turn that over to her to let her talk to you about some of the excitement in that area.
Oh, thank you, Matt. And Matt is incredibly humble and didn't mention that he was a leader in both of those international randomized controlled trials that he just spoke about that have revolutionized the approach to treatment of advanced and recurrent disease. But yeah, so we've identified that uterine cancer may be one of the last bastions of HER2 positive tumors, and that HER2 positivity is more likely to occur in some of those poor prognostic non-endometrioid subtypes that we really want to help patients, in terms of improving their survival outcomes when diagnosed with these cancers. And so this uterine serous and the uterine carcinosarcomas are among those that have up to a 20 to 30 to 40% rate of HER2 positivity. And several of us have been studying this question for some time and found in a randomized controlled trial that when added to conventional like carbotaxol chemotherapy in patients, especially with advanced stage disease treated in the upfront setting after hysterectomy, that the addition of an anti-HER2 monoclonal antibody, trastuzumab, otherwise known as Herceptin to many, improved both progression-free or remission-based survival as well as overall survival in that population. But that sort of spawned, there's just been a revolution right now in novel drug development, and now a novel class of drug called antibody drug conjugates that are more selective at targeting, delivering drug to the, within the cells and to the cancer cells. There's a number of anti-HER2 antibody drug conjugates being developed that show great promise for treating this disease, and including an antibody drug conjugate called Enhertu, among others, known as trastuzumab deruxtecan, that have shown really impressive response rates in patients with recurrent, heavily pretreated HER2-positive uterine cancers, as well as other types of gynecologic cancers as well. And so it's, molecular medicine is helping us realize the promise of cancer care for patients who previously had very few treatment options available to them. So it is an exciting time. I will say, however, that these clinical innovations in care won't matter if access to treatment is undermined, or if we don't understand sort of the disparate incidence and types of cancer and responses to treatments in different populations. And so it's really important in our clinical trials. A big focus at the National Cancer Institute and within our cooperative groups like the NRG Oncology and GOG Foundation are really ensuring that we're enrolling enough patients of ethnic racial diversity so we can best understand how different populations respond to these novel treatments and to conventional cancer treatments as well. And that's going to hopefully allow us to further improve outcomes for all patients with these diseases.
That just sounds like such sophisticated molecular and genetic profiles need to be performed on these pathology specimens. So another reason to go to a high volume center that can perform them. And I don't know what an immune checkpoint inhibitor is. Is that something? Can you just explain to me in layman's terms what this means?
Yeah, so you probably see them advertised on TV. You see Keytruda advertised. You see, I often tell patients, well, do you remember when President Carter had his brain tumor? He received an immunotherapy for his malignant melanoma, and that, took care of his brain tumor. That was one of the early success stories we had with these new class of drugs. And basically, cancers can hide from our immune system by using certain molecules. And basically, the checkpoint inhibitors kind of unmask the cancer so it's seen by the immune system, and really has led to, dramatic, not just a little bit of prolongation, but we're starting to use the cure word here, where we see patients that really were never cured before being cured with immune therapies.
That's amazing. I mean, I cannot believe you said that some of these uterine cancers have a worse prognosis than ovarian. I mean, ovarian has for so long been just this like fatal killer. And the fact that this is taking over just speaks to need for more study in this area. So that is really fascinating. I find that very interesting. So then you give those adjunct immunotherapy and monoclonal antibodies, and then give the Taxol, carbo, and radiation or whatever else. And then it sounds like the progression-free survival and recurrence rates have decreased.
That's right. And even for one of the drugs, we have mature overall survival data. So yeah, it's making a big difference for these patients. We're actually using less radiation than we were in the past as well. So, a lot of the, back when you're OBGYN resident, you remember all the radiation complications that we dealt with on our service. A lot of that's disappearing as we're using much less radiation.
That's amazing. That's really cool. Well, where do you see us going in the future? I mean, obviously call for more research, more funding. What are like some other things on the horizon that you foresee may be coming?
Yeah, I think you really hit it. We're trying to personalize care, and that's through molecular-based medicine. And the minimally invasive surgery, I think, has really been fairly standard now for most patients with endometrial cancer. We're able to get small incision surgery. It seems to be equally efficacious as far as how it treats the cancer. And patients are often able to go home the same day from their surgery. So the minimally invasive surgery, we feel, is quite standard of care now for patients with uterine cancers. As far as what type of therapy to get, that's still this evolving factor. Whether you should have radiation, chemotherapy, or just watched carefully, or undergo targeted therapy with immune therapy. All those things are still in development, and trying to decide what the best therapy is still being developed. That, as Dr. Fader mentioned, utilizing HER2-directed therapies. We have some really active antibody-drug conjugates now, which should really revolutionizing the way we treat these cancers. So it's not just HER2. There's other targets that are being developed. And I think the future is bright. It's a really exciting time to be an oncologist because we're actually making a difference. And we're going to turn the tide on this deadly cancer.
I love that answer. And I don't have anything further to add to the therapeutic approach and the diagnostic approach. I think that a lot of interest remains in the possibility of screening for endometrial cancer. We currently do not have an FDA-approved screening test. We have an organ that we could potentially sample for screening, unlike with some of the other intra-abdominal cancers. However, as you mentioned, Amy, earlier, it's very invasive and uncomfortable to think about undergoing endometrial biopsies, routinely, and then in whom would you do that? And so there's a lot of interest in research happening in that area about, is there a high-risk population? And we know, for example, that patients with Lynch syndrome, or those patients who have a genetic or inheritable risk for endometrial cancer and colon cancer, are right now the only population sort of approved by national guidelines for screening after the age of 35 because of their higher overall population-based risk of cancer. However, there are studies happening at centers like WashU, Hopkins, Mayo Clinic, where we're looking at novel approaches to potential screening that won't be as invasive, using vaginal tampons to detect some of these molecular markers that we know are associated, these tumor driver mutations that may be associated that are genetic signatures specifically for endometrial cancers, using the PAP test and repurposing that, which is something colleagues of mine at Hopkins have looked at intensely. And then looking at things like cell-free tumor DNA in the bloodstream, as another mechanism as well. So there's really exciting diagnostic research happening right now and potential screening research. It's too early to say what if that's going to become prime time or not, but I think it's an important focus right now for us as well in terms of preventing and diagnosing early.
Yeah, that's such a good point. I mean, if we can look at cell-free DNA to diagnose fetal or in utero conditions, genetic conditions, if we can, I hear there's an endometriosis blood test in the pipeline. There's an ovarian cancer one that I heard about like 10 years ago. Are we any closer on that or not really? Maybe a little closer?
Maybe a little closer and still not ready for prime time.
Not ready. Okay. And then I would be remiss if I didn't ask about AI. Is like, what's AI going to be doing for endometrial cancer or gyn-onc? Or, because I know here at the clinic, we have this big push on targets and using this supercomputer, this IBM supercomputer, to do a quantitative analysis and like sort through all the targets. Is that something that's happening in gyn-onc? I just don't know.
I think AI certainly has a lot of potential here and is being currently studied in diagnosis and staging through analysis of histological slides. We do use AI-based programs with robotic surgery. And, there's a lot of research here being done in this arena. Matt, I don't know if you have anything you want to add to that.
I would say it's gotten complicated enough that we need the help of AI to help guide us with all the inputs. Dr. Fader and I do this for a living all day long, but the average practicing oncologist, may not have that many patients with this problem. So allowing all that good information to get to the patient and really allow personalized care everywhere to, narrow that, rural gap and things. I think that's where AI could really help us.
Yeah. I mean, I just talked to one of my urologic oncology colleagues. We're in the surgeon's lounge. I love the surgeon's lounge because it's like where all the things happen. But essentially, we were just talking about AI. We're raving about ChatGPT. Definitely use it for letters of rec, med student evals, all the things. People were raving about it at the boards in April. So many conversations about it. People are using it for residency application or fellow applications, high-level stuff.
That's a great point. And we're using it some at Hopkins for denial and insurance approval letters for novel therapies and other, imaging denials and that sort of thing, which is, huge administrative burden for all physicians right now, as you know, but it particularly impacts patients or cancer care providers because of all of the tests that we order and the treatments that we utilize in our armamentarium. And so I think that's an excellent point. How can we ease the administrative burden and, more importantly, get care to patients that need it at the right time? So,
well, he was telling me that they used this Llama, which is, I guess, the meta version, look at renal cancer specimens. And it was really good at reading the path reports and looking at the size. So analyzing all of this, and it performed just as good as, or just as well as a human or, predictive models or whatever. So I'm just really curious how it's going to transform, because it's and the other thing to know about these inputs, this is a side note, but I just have to mention it, is if you are nice and say please and thank you in the inputs, because it's made of all these other inputs, it's really sensitive to tone. So you'll get better results if you're polite to your AI input. So I'm just telling you this because I didn't know, but when you ask it, just put please in a nice way.
Great point. I would have not have known.
I know. Instead of do this, if you just say it in a nicer way, I guess AI will work for you better, just like with a person.
Kindness matters.
Yeah, even with your AI machine. Well, anyway, I just wanted to see if there's any other parting thoughts or wisdom that you want to pass on to our listeners, because I just find this so fascinating. This is mind-blowing how much things have changed over the course of my career. I love it. It's amazing, but it's also bad because it's getting better for ovarian cancer, getting worse for endometrial. So I have hope because you guys are on the case. And it sounds like there's a lot of things in the pipeline. What are your thoughts?
Yeah, I think you're right on target that, there is reason for hope. And I think we're actually looking at some of the GLP-1 medications to see if we can counteract hyperplasia with that. You're already seeing, these headlines, babies born because of Ozempic. And so we were reversing some of the abnormal hormone milieu that these patients will have with these new drugs. So if we can attack the obesity epidemic, we can attack the hormonal imbalance, I think we can make a difference in women's lives with endometrial cancer. So, but screening, patient awareness, physician awareness, all are very key.
Agree wholeheartedly. I don't know that I have anything to add to that. I think that weight is the fifth vital sign, and paying attention to that. And if we don't have time in our practices or the expertise to make sure patients are getting referrals for nutritional and obesity, weight counseling, we know bariatric surgery and these newer class of drugs are helping patients significantly. Consider progestin-containing IUDs in high-risk women, or patients with symptoms that don't, and we use that in some cases to treat endometrial cancer in patients when they're appropriate and desire fertility. And so we all have to do this together. This has to be a collective action here to reverse these public health trends, and just feel very privileged to be part of this movement.
Well, thank you so much for sharing your expertise and insight on this topic. I think it's really timely, and I know our listeners are going to get a lot out of it. So thank you so much for coming today. We really appreciate it.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor's Version Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Jamila Kennebrew.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.